Hello, friends. Today I have come up with another very important topic, that is amniotic fluid embolism. This is important from the practical point of view. This is a very, very dreaded and sudden complication. It comes like a bolt from the blue to the patient as well as to the patient party and to obstetricians. Everybody should be aware of this, and we should be prepared to face this at least once in our lifetime. And in the examination, of course, this case will not come as a clinical case because amniotic fluid embolism is an emergency. But definitely, because of that, it will be a long question in the theory paper. So you should know everything about amniotic fluid embolism, both from the exam point of view, also later in life, how to face or tackle that particular situation. So let's go into the topic straight away, amniotic fluid embolism. What is amniotic fluid embolism? It's a rare condition, as I already told in the introduction. It's unique to obstetrics. You don't see this anywhere else, of course, because there is no amniotic fluid in anywhere in any other situation. So it's a rare or unique to obstetrics. First described in 1941 by Steiner and Lushberg, they must have been, exacerbated how to explain to the patient party, and they found that maybe at postmortem, some squames in the vessels of the lady. So that's how they thought it could be an amniotic fluid embolism. There are three classical features. This is a very important slide. So you must remember this, and then you will have no confusion in life regarding amniotic fluid embolism. What are the three classical features? Number one is it's an abrupt onset of severe hypotension. That is very, very, very important. Sudden drop in the blood pressure. Abrupt onset of severe hypotension, hypoxia, both are hypotension and hypoxia. And then, of course, consumptive coagulopathy. So these are the three classical features of amniotic fluid embolism. So I call it H2C, not H2O. All of us are aware of H2O, that is water. And easy to remember here is H2C. This is my own acronym. I thought it is very easy to remember. So hypotension, hypoxia, two hypos, and consumptive coagulopathy. In fact, here also it is hypocoagulation factors, if you want to remember that way. So consumptive coagulopathy comes into picture. There can be great individual variation in its clinical manifestation. This has to be remembered. Not everybody will go through these classical features, and it is not one after another. They could happen simultaneously, though consumptive coagulopathy takes a little more time because there has to be initially consumption of all the coagulation factors. Only one of the three classical features may be predominant in a given woman. So there may be only hypoxia, there may be only hypotension, there may be only severe bleeding. So all you should suspect amniotic fluid embolism. So this is a very important slide. I hope I have made it extremely clear about this. H2C, remember. What is the incidence? Thankfully, it is very, very less, 2 to 7 per 100,000 births. Otherwise, it would have been very, very scary to deliver a pregnant lady. And also, it would be very scary for the ladies to go through pregnancy and childbirth because it can happen even after normal delivery, the so-called normal delivery. Associated with high mortality. In fact, what is said in many textbooks that if the patient survives amniotic fluid embolism, the diagnosis should be re-examined. Look at that. That means if you diagnose amniotic fluid embolism, mortality is almost 100%. If the patient survives, then it was not a case of amniotic fluid embolism. That being the case, we should be extremely cautious, extremely careful, extremely sensitive about these issues, and we should be on our toes all the time. That's why I respect obstetrics. I respect obstetrics because all of us have to be on our toes. I only wish that the patients and patient party realize this. We are on our toes all the time. We, in fact, give most importance to our patients than our family. So I hope this message goes across the community. What are the predisposing factors? Rapid labor or precipitate labor. So you must anticipate in such cases. So it's only a doctor who anticipates, doctor who is prudent, doctor who is prepared, he would be successful. He should think of all possibilities. How do you think of all possibilities? You think of plausibilities when you know the risk factors, when you know the predisposing factors. So that's why this slide is again very important slide. Prolonged labor. So one hand it is precipitate labor, on the other hand it is a prolonged labor. See what happens, there are lots of sinuses, open sinuses in the uterus. So both in precipitate labor and in prolonged labor, there are good chances of these sinuses sucking some of the amniotic fluid, some of the squames, and even sometimes air, especially after the removal of the placenta. So this actually happens in every single case. Again, thankfully, every single lady will not go through this problem. Meconium stained amniotic fluid. Yes, this is not at all very difficult to diagnose. So once you do ARM, you will know that whether the amniotic fluid is meconium stained or not. And you must be careful in such patients. Tears in uterine and other large veins. So this happens maybe in a uterine rupture or some cervical tears or other tears. So these are the situations where the vessels are open and they will have a sucking mechanism. So they will suck out all this amniotic fluid, air, and other things. What are the other risk factors? Elderly age. Of course, extremes of age is a factor in most of the situations. So also here, obese patients. Yesterday, I was talking about the obese patients and their management. So you must anticipate amniotic. I don't think I told about amniotic fluid embolism in yesterday's lecture, but today I'm highlighting obese patients run this risk as well. Medical disorders, GDM, anemia, heart disease, even preeclampsia. So all of them run the risk of amniotic fluid embolism. Eclampsia, there you are, especially in eclampsia patients, when they are in that convulsive phase, there could be a possibility. Placental abruption or previa. Again, whenever there is massive hemorrhage, this hemorrhage slightly goes into the vessels and through that they gain into entry into the lungs and other situations. So placental abruption, placenta previa. Polyhydramnias. This is definitely because of the increased pressure inside the uterine cavity. They can easily go into the open sinuses. If you look at this slide, almost every high-risk patient, high-risk obstetrics patients are prone for amniotic fluid embolism. I made a grand statement right in the beginning of the class that even after a normal delivery, normal low-risk patient can have amniotic fluid embolism, which becomes extremely difficult to explain to the patient party. Even if you explain, it becomes impossible for them to accept that because everything went off well and suddenly the patient dies because of amniotic fluid embolism. Post-term pregnancies, like prolonged labor, post-term pregnancy is also one of the risk factors. In other words, all high-risk pregnancies are automatic high-risk factors. So it's not very difficult for you to mention them. So how to remember that? It's nothing but the chapters in obstetrics textbook. So that's how I make it simple for the undergraduate students. But postgraduates, the difference I have always been telling that the difference between undergraduate and postgraduate student is that undergraduate students remembers and answers, and it is appreciated. But postgraduates cannot do that. You can't be just answering by memory or by just knowing the facts. You should know the reason behind it. You should be able to explain that. Like I have been explaining for every particular point, I'm giving some explanation. Labor induction and augmentation with ARM. See, I have highlighted induction augmentation, but I have highlighted ARM much more and I've changed the color also. That means ARM is the culprit. So you may be doing ARM to induce or to augment labor, but then you will be worried next time before you do ARM. There is nothing to worry, but we have to be careful because it is more common in patients like of having polyhydramnios and other risk factors. You have to be careful while doing and before doing ARM. So now onwards, you will think ARM is a simple procedure, but then the consequences of that or the aftermath of that can be larger. So you'll be very careful. You won't do ARM in isolation. Sometimes I have seen the postgraduates have a habit of doing ARM when nobody's around, just to practice or just to learn. But suddenly that patient may have amniotic fluid embolism. So you must do everything, any procedure, for example, you have to be ready, prepared for the aftermath of that. Even simple things like giving an injection, there can be anaphylactic reaction. So you should not do anything in isolation. You should do when everything is ready around you to resuscitate the patient. Injudicious use of oxytocin for augmentation. Again, of course, now oxytocin is hardly used for induction. It is not used at all in a way. Augmentation, yes. After ARM, we do sometimes use oxytocin, and if you do not have the machine to actually monitor or control the dose, and if you simply do it manually, sometimes more oxytocin will go, and that can cause problems. So always it is said that better to use a machine to give all these kind of drips, and you have to first adjust the dosage by running the normal drip, and then you have to add oxytocin to that. Straight away, don't start with the oxytocin mixed fluid. Obstructed labor. Of course, there's a big chance of uterine rupture in obstructed labor, and all the sinuses will be open there. And that's why there is more chance of amniotic fluid embolism. Same happens with cesarean section. In fact, in cesarean section, I really don't know. We would have all done thousands and thousands of cesarean sections, and luckily nothing would happen. But in cesarean section, all the sinuses are open to the air. We are actually cutting open the uterus, and I'm sure some amount of air, some amount of gas, some amount of amniotic fluid, and everything goes into the system, but it is not severe enough. It all depends upon the probably body reaction also. Now I think of it. So maybe that's the reason only very few ladies will have amniotic fluid embolism. So also again, forceps and vacuum delivery. This usually why this happens, it's an easy guess. In the previous slide, you saw prolonged labor, right? In the prolonged labor cases only, you use forceps and vacuum. So it may be a mixture of forceps and vacuum and prolonged labor, everything. It's not just because you have used vacuum or forceps. So you'll be wondering how forceps can cause amniotic fluid embolism, but it's not the forceps. It's the reason for forceps. It's the indication for forceps. Etiopathogenesis. It's not uncommon, of course, that's what I said, for some amount of amniotic fluid to enter the maternal circulation, especially at the time of normal delivery, right? Through the open sinuses and or a minor breach in the physiological barrier between the maternal and fetal compartments. But somehow, not every single lady will have this problem. Not somehow, thankfully. Squames and other cellular elements of fetal origin and trophoblasts are also identified in maternal peripheral blood at the time of delivery. So I think this happens routinely in every single person, but not every single person will react the same way. They are usually innocuous, but in some amniotic fluid constituents initiate a complex series of pathophysiological sequelae such as hypertension, cyanosis, pulmonary edema, dyspnea, ARDS, cardiopulmonary arrest, and coagulopathy. So this is a classical feature or classical things that happen. Hypertension obviously will lead to decreased oxygenation, so cyanosis is the next, and pulmonary edema, dyspnea, which is a common occurrence, and both of them will lead to ARDS. And finally, of course, it has to be cardiopulmonary arrest. Both the two important organs, that is the heart and the lung, which complement each other. And if they fail, that's the end of it. Finally, of course, the coagulopathy is also one of the accompaniments of all these things, the triad of H2C, hypertension and hypoxia and coagulopathy. Seizure, of course, whenever there's oxygenation, hypoxia, there can be seizures as well. The wide range of clinical manifestations may lead to variation or delay in accurate diagnosis in many. Because what happens is we are always somehow positively thinking and We hope that everything will go right. And we try to ignore minor problems. Suppose the BP drops down, we think that maybe it is because of BPH. Or if there's oxygenation problem, we think that patient is hyperventilating. Or if there's some amount of bleeding, we don't think of coagulation or consumptive coagulopathy always. So this is like a hopeful thinking. That's exactly why probably sometimes they advise that you must not treat your own relatives and, daughters and others, because you always tend to think nothing is wrong, nothing is wrong. You don't uh, anticipate or wish bad things. So that's exactly where. But at this juncture, I now really wonder how I did a cesarean section on my own daughter. Thankfully, again, nothing went wrong. But it's a very risky situation that obstetrics, presents to us. We have to be all the time alert, especially when we are doing any procedure. Amniotic fluid and its constituents have different actions on cardiovascular and coagulation system. So endothelin 1 expressed by fetal squamous, phosphatidylserine expressed by amnion, and complement activators incite a anaphylactoid reaction. So this is on the cardiovascular system, and tissue factor in the fluid incites coagulation. This is on the coagulation system. So on the cardiovascular system, it is some sort of an anaphylactoid reaction, whereas on the coagulation system, it is a different type of reaction. So tissue factors play a major role in coagulation disorder, whereas endothelins, phosphatidylserine, and complement activators play a role in anaphylactoid reaction. So these are the basic triggers for the problems that we see in amniotic fluid embolism. What is the pathophysiology? Fetal debris, embolization, and toxicity increase with the volume of amniotic fluid. That's exactly why in polyhydramnios it is more common and more dangerous. And the amount of meconium contamination, again, see, a pure water itself, a fluid itself is dangerous. Sometimes, when we drink water also, we get a little bit choked or we feel like coughing. Now, if the water has got sugar syrup and if it is stuck in the throat, we feel it more harsh, even if it is sugar syrup. Okay, I'm sure all of you must have experienced this. So amniotic fluid itself is bad. And imagine if amniotic fluid contains meconium, it will be worse. So that's what it is. There are different phases of amniotic fluid embolism, and it is very important to understand this, because if we understand this, then we probably will be able to abort an amniotic fluid embolism, or at least tackle that at early stage and try to save the patient. So in the initial phase, what happens is there is pulmonary and systemic hypertension. All this while I was talking about hypertension, hypertension, hypertension. Yes, hypertension is the last common pathway. But before hypertension, the body always tries to, compensate the problems by, its own mechanism, increase in heart rate maybe, or increasing blood pressure, hypertension, in an attempt to supply blood to all possible organs, especially the lungs and alveoli. So in the initial phase, there will be pulmonary as well as systemic hypertension. Hypertension initially. There is profound oxygen desaturation immediately. Maybe that's the reason there is a compensatory hypertension, cause of neurological injury in most survivors. So this oxygen desaturation will give rise to neurological injury. So one leads to another. The patient usually deteriorates so fast, there will be multiple organ failure, including the neurological injury because of hypoxia. All of us know that hypoxia of 20 minutes can cause permanent damage to the brain. What happens? What else happens in initial phase? There is right ventricle is massively dilated and akinetic. Of course, all the blood comes to the right ventricle first, you know that. So then it becomes massively dilated. Left ventricular activity is obliterated due to vigorous contraction. So there's so much of blood coming from right ventricle into the left ventricle. And then, left ventricle is the one which has to pump it out. and it goes into vigorous contractions. So it almost becomes like a standstill. It's almost like a ventricular fibrillation situation. The failure to transfer blood from right to the left heart because of severe and unrelenting pulmonary vasoconstriction. See, vasoconstriction is the cause of hypertension. So there is vasoconstriction everywhere, including the pulmonary vasculature. So this pulmonary vasoconstriction will not allow the left ventricle to function well. So there will be a failure of transfer of blood from right to left heart because of this. So the initial phase is that of a sort of a defense mechanism, I can say. There'll be vasoconstriction. So there will be pulmonary as well as systematic or systemic hypertension, and followed by, of course, all the drama in the heart. Right ventricle is dilated, left ventricle cannot function, it stands still, it is stunned, both because of the excessive or overwhelming blood as well as because of the pulmonary vasoconstriction. Now, the initial phase, this phase of vasoconstriction, hypertension, and deoxygenation or desaturation is followed by the next phase, that is decreased systemic vascular resistance. Okay, this is the time the body gives up. Initially we struggle a lot. Now, let's say we are drowning. There will be hyperactivity. The light or the lamp, when it is going to go off, it is very brighter. Same way, just before the death, there will be hyperactivity, but soon it will be followed by lack of resistance, systematic vascular resistance. This is the one which will cause hypotension. So it is diminished cardiac. There will be diminished cardiac output, not because there's no blood there or not because the pumping action is sort of lost. So the left ventricle is overwhelmed. It is gone into fibrillation, ineffective pumping. So there will be diminished cardiac output. So these two, this also will contribute to the hypertension. All of us know that the hypertension is, or blood pressure, normal blood pressure is nothing but cardiac output multiplied by peripheral resistance. So here you have both loss of resistance as well as diminished cardiac output. Obviously, there has to be hypotension. Women who survive beyond these two phases, what happens? There is invariably a consumptive coagulopathy. And usually they have lung and brain injury. So once they survive this phase, immediately they go into consumptive coagulopathy. And usually they will have lung and brain injury because of the hemorrhage or hypoxia. Risk factors for venous thromboembolism: there is increase in the blood coagulability. Venous stasis. See, consumptive coagulopathy means initially there is usage of all the blood and there will be increased coagulation. And then once all the coagulation factors are consumed, it will be the phase of bleeding. Initially there is coagulation. That's why it's called consumptive coagulopathy. All the coagulation factors are consumed and then there will be DIC. Venous stasis occurs because patient is sort of immobile. Trauma to the vessel wall. These risks are heightened during pregnancy, as it is, we know that, and particularly following cesarean section and puerperia. Patient is mostly immobile. That's why now for long time we have been telling that early ambulation is the secret of early recovery. So especially if the patient has been not ambulatory during the antenatal period, either due to preeclampsia or due to any kind of bed rest given in placenta previa situations. So these are the patients who are going to have it worse. That's why there's hardly any role for bed rest in antenatal situation or even postnatal situation. Ambulation is always better. This, recumbent position or laziness comes if the patient is obese. So everything is a package. So amniotic fluid embolism carries dual risk of effects of embolism as well as hemorrhage as a consequence of DIC. So on one hand, all the anaphylactic type of reactions or embolism reactions will happen. On the other hand, there is hemorrhage and hypertension. So it is the perfect recipe for death. What are the components of clinical pathological effects? Embolic phenomena, which could be minor acute pulmonary distress. It is expressed as acute pulmonary distress, or major is death only. At the postmortem, embolic material is seen in the lungs, fetal squames, vernix, laryngomalacia, and meconium. So this is the proof. In fact, amniotic fluid embolism have to be proven by presence of these things. And we only hope that we don't have to prove this at the postmortem. Maybe we can prove this by some other means when the patient is alive. There is no denial that the embolic material is seen in the lungs, that is fetal squames, vernix, laryngomalacia, and meconium. That's the proof. That's the proof of amniotic fluid embolism. Second one is hemorrhage. Embolism is over. Hemorrhage. These are the two components I told you. The patient's death is mainly because of the phenomena of embolism as well as hemorrhage that immediately supersedes. The mechanism of coagulation failure is uncertain, but we all know it is hematological findings include depletion of fibrogen, consumptive coagulopathy. I am repeating this many, many times. Initially, there is coagulation. Yes, but this coagulation will snatch away all the coagulation factors. So that's why it's called consumptive coagulopathy, in the sense there is depletion of fibrinogen, thrombocytopenia, low levels of factors 5 and 7, and a variable degree of enhanced fibrinolytic activity. Whatever clots are formed also are lysed. These findings suggest that the coagulation defect is primarily due to DIC. What is DIC? Disseminated intravascular coagulation. It sounds, there is coagulation, but the other name of this is consumptive coagulopathy. That means all the coagulation factors are consumed, nothing is left for further coagulation, so there will be hemorrhage. So this may be slightly difficult for you to understand initially. The word is disseminated intravascular coagulation. If there's coagulation, why should there be bleeding? It's not like that. It's consumptive coagulopathy. What's the clinical picture? Clinical picture is that of a high drama. High drama in the labor room or in the OT. It's very dramatic. In fact, you are not given any time to act also. Even before that, we can't even think. So we have to work at the spinal level. That's exactly why this lecture is very, very important. Remember this lecture every time you deliver this patients. Gasping of air in the late stages of labor or immediately postpartum. So this should give you some clue that this patient is sinking. This patient is going towards amniotic fluid embolism. So sudden change in the patient's behavior, dramatic changes, gasping for air. So you must start acting immediately. How to act? I'm going to talk in the end of the talk. Seizures, patient will start convulsions and cardiorespiratory arrest. So everything happens together. You don't know whether to go for CPR, whether to think of seizure, tackling, whether to give oxygen, intubation. Everything has to be done simultaneously. If the patient is already in the OT, maybe slightly easier because anesthetists are around, and even though patient is under spinal anesthesia, immediately they can do intubation, they can give cardiorespiratory resuscitation, and you can tackle the problem. But if it happens in labor room, it's going to be slightly difficult. So that's why the obstetrician should be well versed with all these resuscitatory methods. That's why I really salute the people who deliver the ladies, pregnant ladies in primary care center, secondary care center. It's very easier to work in a tertiary care center like Manipal, but it is extremely difficult to work in primary care setups in nursing homes, and especially it's very in the cities, very difficult to get everybody in no time. So I only hope that the patients realize all these difficulties of the doctors, especially the obstetricians. We actually sincerely work for the betterment of the patient. No doctor on earth would wish to lose a patient. That is not even in the remotest corner of our minds and hearts. But somehow we are expected to deliver, and deliver in the sense not only the baby, deliver everything. we have to deliver the right things to the patients. That is the high expectation, which is now root cause of all problems. Massive hemorrhage through DIC, everything is happening. All drama is happening. Patient is gasping, she is throwing fits, there's arrest, there is bleeding. You don't know where to stop the things, whether to close the tap first, whether to intubate, whether to tackle the seizure, whether to give oxygen. Everything is happening. The signs and symptoms are varied and at times quite subtle and include respiratory distress. It may be just, having difficulty in breathing, or maybe hyperventilating, hypotension. May not be again as serious as less than 80 systolic. Chest pain, of course, is another thing, fever and hypoxia and arrhythmia. So these are some of the symptoms which should alert you, and it should make you start reacting immediately. Timing of occurrence, of course, after the artificial rupture of membranes, in labor, spontaneous rupture of membranes associated with strong uterine contractions, usually in the last stages, closely related to the time of rupture of membranes, after cesarean section, and immediate postpartum period. So rupture of membranes, rupture of membranes, rupture of membranes. So rupture of membrane is not a simple thing. Immediately after rupture of membranes, look at the patient's face, look at the BP, look at everything. Don't run away after rupturing the membranes. Rupturing the membranes is a simple job anybody can do. But what others cannot do is anticipate problems. So as a doctor, as a PG, as an obstetrician, responsible one, prudent one, you must anticipate all problems. What are the signs and symptoms? In almost 50% of the cases, there is past history of asthma, urticaria, hay fever. So you remember I told you there is something like an anaphylactic reaction. It's an allergic type of reaction. So patients have already the history of allergy in the form of asthma, urticaria, and hay fever are more prone. Generalized pruritus, bronchospasm, hypertension, and tachycardia within a few minutes. I've explained this many, many times, so easy to understand. Respiratory distress, cyanosis, pulmonary edema, and retrosternal pain. Everything, all possible emergency symptoms. Patient is having bronchospasm, breathing difficulties, sudden collapse, hypertension, tachycardia, cyanosis, pulmonary edema, retrosternal pain, distress, bleeding. Everything is happening. So acute collapse and shock are the two important things. Hypotension, you remember what I was talking about, and consumptive coagulopathy leading to hemorrhage and hypoxia. Coagulation failure, this may not develop until a few hours after the embolism, but is a future virtually in all cases that survive an initial shock. That's what I told you. That's why I put it as number 3, H2C. C happens little later. First one to happen is hypotension. Second one to happen is hypoxia. Sudden death, of course, this is not a symptom. This is the end of the life. How do you diagnose? Of course, by this time, you should not have any confusion regarding the diagnosis. An irrefutable diagnosis cannot be established unless careful postpartum examination is performed. This is the tragedy of the diagnosis. Diagnosis is made on the postmortem table. But we should be able to tackle that beforehand, provided we have anticipation. Amniotic fluid embolism should be considered in all cases of unexplained collapse. Of course, this is what most of the time we think of when there is a sudden death, but patient will not accept that. Clinical picture, as described in the previous slides, blood coagulation studies, and they may die within a few minutes, if not, may develop angioneurotic edema, abdominal pain, and diarrhea. These are all, again, another ominous signs. What is the treatment? No, this is very important. Immediate, I have put it in bold font, italic, as well as in red color. Immediate resuscitation is necessary to avoid high mortality rate. Resuscitation includes everything: cardiopulmonary resuscitation, intubation, oxygenation, and thinking of anticonvulsives, thinking of the massive blood transfusion, all at once and together simultaneously, not one after another. Treatment is mainly symptomatic and emergency care because we know it has happened right in front of our eyes. It is not because of an underlying disease. So it's basically, we are treating all that is happening, basically symptomatic and emergency care. In a collapsed and shock patient, and consists of immediate cardiopulmonary resuscitation, as I told you already, CPR, and tracheal intubation with oxygenation and ventilation, yes, and support of the failing myocardium, maybe inotropics have to be considered, circulatory support with rapid blood component replacement and coagulation failure. That's all. There are three things happening: cardiopulmonary arrest, CPR. There is hypoxia, intubation, and oxygenation. There is a sort of myocardial stunning. So that's why you have to give inotropes. And then there is coagulation failure. You have to give component. Hydrocortisone, large doses intravenously. This is always the savior. During internship and PG days, we used to think of hydrocortisone. We thought somehow it will save everybody. It's a savior. Aminophylline, intravenous for respiratory distress and all allergic problems that are accompanying. Even for anaphylactic reaction, we think of this. Correction of acid-base balance, best done by the anesthetist around. In undelivered women undergoing cardiopulmonary resuscitation, consideration should be given to emergency cesarean, delivering to optimize these efforts and improve newborn outcome. Now, this is a little funny. Cesarean section also can give rise to amniotic fluid embolism, and you are treating a patient of suspected amniotic fluid embolism undelivered, maybe at the time of ARM. But cesarean section is the answer again, because we have to clear the uterine cavity. And then, of course, this also has an advantage that there are many people around in the OT. Treatment in suspected amniotic fluid embolism, consider anticoagulation therapy. Intravenous unfractionated heparin have now been introduced with the promising results, followed later by the coumarin derivatives. Placement of vena cava filter. Prognosis is poor in most cases for both. There is increased maternal and perinatal mortality. Of course, perinatal mortality goes without saying. In fact, we had a case long back in Manipal where the patient was referred to us with a IUD, and then we were thinking of that in labor, of course. She was already in labor, and suddenly she also had amniotic fluid embolism. We lost both. So that's the case. There's something called air embolism, which may occur following clinical situations. Number one is catheters for central venous pressure measurement, intravenous infusions under positive pressure, placental site unsafe abortion, and the air enters right side of the heart and is churned in froth. Thus, no blood enters the heart as it just compresses the froth. Probably at least 200 ml of air is needed to cause death. So 200 ml is quite a bit. So we should be very careful when we do all these procedures, cathetering of the central veins, and intravenous infusions also sometimes under positive pressure, and placental site during unsafe abortions. How do you tackle that? Investigation and treatment. ABG, of course, shown an alveolar arterial gradient, and radionucleotide imaging if it is available. If the results are normal, PE is excluded. Venous ultrasound or immediate plethysmography, pulmonary angiography, and of course, place the patient on her left side and aspirate the air from the right ventricle with a needle or a syringe. So finally, I'll end this topic of amniotic fluid embolism with the algorithm that has to be followed. Amniotic fluid embolism is not there, then of course, initiate appropriate test. Whereas if it is present, then you have to think of anticoagulant. Okay? If there is anticoagulation present, then inferior vena cava filter should be thought of. If it is not there, hemodynamic stability should be considered. So if anticoagulations I'll repeat, if anticoagulation cannot be given, CI means contraindication to anticoagulation, then inferior vena cava filter. If there is no contraindication, you think of the hemodynamic stability. So hemodynamic stability is present, but there is contraindication to thrombolytic therapy. If it is not there, thrombolytic therapy, then of course anticoagulant. If hemodynamic stability is not established, or if there is contraindication to thrombolytic therapy, you have to consider IV unfractionated heparin, then oral anticoagulations. So this is about the amniotic fluid embolism, air embolism, treatment, and the algorithm. I hope you enjoyed this talk, but what is important is to understand this talk, and you have to keep this talk in mind throughout your obstetric career. I wish that no patient dies of amniotic fluid embolism in this world. Thank you so much.